Hi, my name is Samantha Gordon, and I'm going to be presenting the full blood count results for this assignment. The client was a 55-year-old female with a BMI of 28, so she's overweight. Her blood cell results were as follows. Primarily, the abnormal results were the white blood cell count, which was elevated, particularly the neutrophils and the eosinophils. An increase of white blood cells is classified as leukocytosis. For adults, this is usually a reading more than 100 mils, and it's a common laboratory finding. Distinguishing and deciding what caused this is important for the diagnosis and treatment of the patient because there's many differential diagnoses. Neutrophilia is a subcategory of leukocytosis, which primarily is when the neutrophil count is elevated. This primarily indicates that there's illness or inflammatory conditions, but can also be influenced by lifestyle factors such as stress, exercise, and smoking. Acidophilia is also a subcategory of leukocytosis. This is more common with allergic reactions, parasitic infection, or cancer. The causes and conditions can vary, and here are a few listed there. And we're going to go through a bunch of them. Genetics and family history can play a part, such as conditions like Down syndrome and idiopathic neutrophilia, which can cause elevated white blood cell count. Medication use, such as antibiotics, aspirin, corticosteroids, vaccinations, and mental health medications such as lithium can also increase white blood cell count. Smoking and recreational drug use, as well as obesity, can also increase. Allergies, which are a primary symptom of an increased white blood cell count, they are more indicated with the raising of eosinophils and can also indicate some bone marrow conditions. Physical and emotional stress also play a part, with intense exercise and mood disorders primarily being a condition that a thing that can cause white blood cell count to go up. Clinical presentations of leukocytosis include temperature changes, difficulty breathing, fatigue, weight changes, enlargement of the liver, spleen, and lymph nodes, skin conditions, pain, vision problems, and some people can just be asymptomatic. The health consequences and complications if left untreated is there can be conditions like metabolic abnormalities and leukemia, or there can be a condition such as hyperleukocytosis or hyperviscosity syndrome, where the blood gets really thick, and that can lead to organ failure, heart attacks, and strokes.
Hi, my name is Rebecca, and I'm going to be discussing Amira's fasting cumulative lipid risk report results. So as you can see, her total cholesterol, her low density lipoprotein, direct, and her non-HDL cholesterol have come back above the recommended reference range. It could be due to genetic factors, so she could have an inherited condition that could cause predisposition to or hyperlipidemia and hypercholesterolemia. Smoking additionally can damage the blood vessel walls and promote fatty or cholesterol-based deposits within the body and increase lipid levels. Hypothyroidism can also do this. Overweight and obesity is often seen in hyperlipidemia. So Amira isn't clinically obese. She has a BMI of 28. However, she is overweight, so that could be contributing. A sedentary lifestyle and certain diets can also contribute to this. So exercise has been seen to increase HDL levels, and HDL is our good cholesterol that helps remove other less helpful forms of cholesterol from the body, and it also helps mitigate the negative effects of LDL cholesterol. Additionally, diets high in full-fat dairy products, animal products, and refined or heavily processed foods can help promote hyperlipidemia and hypercholesterolemia. Generally, these conditions are asymptomatic unless in some we can see xanthomas or corneal arcus on the iris, which are fatty or cholesterol-based buildups around the body. When the pathogenesis is systematic, you can see chest pain, stroke, or a heart attack. If total cholesterol and LDL levels are left high over time, the liver fails to remove or reuse all the cholesterol. So cholesterol resultantly builds up in the blood vessels and can cause atherosclerotic plaques, and it can cause pathogenesis of different cardiovascular diseases such as carotid artery disease or coronary heart disease. In the same way, this pathogenesis can cause a heart attack, and it's seen that there's a linear correlation between the risk of a heart attack and high cholesterol levels. So Amira is at a borderline high risk for coronary heart disease, as the cholesterol reference range for this risk level in adults is 5.18 to 6.19 millimoles per litre, and she's at 6. Also, her increased total cholesterol puts her at a higher risk of a heart attack. She's also at a moderate or borderline high risk for coronary heart disease in regards to HDL levels. Hers are 1.34 millimoles per litre, and the reference range for this risk in adults is 1.16 to 1.53 millimoles per litre. In order to prevent these complications, Amira will have to take certain steps to lower her LDL and total cholesterol levels.
Hi, I am Jamie Benet, and today I'm covering the urine microtest results. So Amira has come into the clinic after having a urine test done that has confirmed both glucose and protein within her urine. So a positive reading of protein in the urine we refer to as proteinuria, while a positive glucose urine test we refer to as glycosuria. So this is a copy of her results. As you can see here, the collection was taken midstream, and it has come back positive with protein and positive with glucose, negative for ketones, and her leukocytes, erythrocytes, and epithelial all seem to be within normal ranges. So interestingly, smoking has actually been found to increase the possibility of proteinuria, especially in patients with chronic kidney disease. It does this by inhibiting the glomerular filtration rate and actually slowing it down considerably. Additionally, proteinuria is a very common symptom of diabetes and is a useful biomarker in the actual diagnosis of diabetes, as is glycosuria. Glycosuria is usually caused by the elevated blood sugar levels. Chronic kidney disease as well, both proteinuria and glycosuria are indicators of. It shows the underlying glomerular disease or renal tubular dysfunction that is very prevalent in individuals with chronic kidney disease. Lastly, proteinuria and glycosuria can be useful biomarkers in the diagnosis of other conditions, such as certain cancers, infections, and cardiovascular diseases. So there is a high chance that Amira is a type 2 diabetic, and as a result, her symptoms we believe would be much more in line with diabetes, just because proteinuria and glycosuria don't actually cause further symptoms themselves. So we would be expecting to see excessive thirst, excessive hunger, fatigue, poor wound healing, blurred vision, frequent urination, and weight fluctuations. There's also been found a link between diabetes, proteinuria, glycosuria, and depression. And lastly, diabetes is also the most common cause of gastroparesis, which is a condition that causes food to stay in the stomach for longer than it should. It involves the sort of damage of the vagus nerve, that is the nerve that usually causes the stomach to do its gastric emptying. So it is important that individuals with protein and glucose in their urine seek adequate treatment for their conditions, because if left untreated, whilst glycosuria itself doesn't cause damaging effects, we believe it does show an underlying condition such as diabetes, which when left untreated can cause long-term and serious consequences such as amputations and blindness. Lastly, idiopathic nephrotic syndrome is caused by untreated proteinuria that has actually resulted in intravascular volume depletion and edema.
I am Alexandra Martin, and I have completed the oral glucose tolerance test, otherwise known as an OGTT. This client is a 55-year-old female with a BMI of 28, which is classified as overweight. Fasting blood glucose results highlighted a fasting level of 6.8 and a 2-hour glucose level of 7.5, with the Royal College of Pathologists of Australia indicating this as impaired fasting glycemia, or otherwise categorised as prediabetes. Predisposing, causative and contributing factors of prediabetes include poor diet, inactivity, increased BMI, age, pre-existing conditions, genetics, and family history. Poor dietary habits significantly increase the development of type 2 diabetes in a pre-diabetic condition, as an increased intake of sugar, saturated and trans fats contribute to insulin resistance. Sedentary behaviour or low levels of physical exercise have also been established as a mediator of type 2 diabetes. Meta-analysis research indicated 112% greater risk of development of diabetes type 2 due to sedentary lifestyle. Insulin resistance is also increased with the elevated adipose tissue mass in overweight or obese individuals. Excessive adipose tissue increases the circulation of fatty acids, which in turn reduces the body's utilization of glucose. Due to the client's BMI of 28, this is likely a major contributing factor. Impairment of B cell function and reduced insulin secretion has also been shown to contribute to the increased risk of diabetes in regards to the aging process. The increased risk of diabetes is shown to affect individuals over the age of 45, with this client at an increased risk due to her age of 55. Pre-existing conditions such as PCOS, hypertension, and/or high blood lipid profiles have also increased the risk of prediabetes development. The genetic link between diabetes and previous family history is also greatly dependent on environmental factors. However, the risk is substantially increased when a sibling or parent has diabetes type 2. Whilst pre-diabetic individuals usually present asymptomatic, clinical signs and symptoms which usually indicate progression to diabetes type 2 are excessive thirst, fatigue, increased urination, headaches, poor wound healing, and skin discoloration commonly located on the back of the neck, armpits, knuckles, folds of the elbows, groin, and knees. The health consequences for this client, if left untreated, include the progression of prediabetes to diabetes type 2, with clinical studies highlighting up to 70% of pre-diabetic individuals develop type 2 diabetes. In both pre-diabetic and diabetic states, the increased risk of development of macrovascular complications is substantial, with both hyperglycemia and insulin resistance contributing to the pathogenesis of cardiovascular disease.